Hello, I'm Dr. Anthony Wheeler, and I'm telling you everything that you need to know about pathology. Now, my future OB-GYN doctors out there, what organ is this? The uterus, right? We're going to be discussing this and much more on this presentation of Uterus Pathology. This is covered in your book, Medical School Pathology and Step 1 Review. You can scan the QR code to get to the updated material. Now, uterus pathology. For some reason I just feel all warm and cozy. The uterus is responsible for incubating human life. Let that sink in for a minute. Okay. The mucosal lining of the uterus is called the endometrium, okay? Endometrium. The endometrium is supported by a smooth muscular wall called the myometrium. Hormonal sensitivity exists in the endometrium. Estrogen drives the endometrium's growth, specifically in the proliferative phase. And progesterone is responsible for preparing the endometrium for implantation in the secretory phase, right? Shedding happens when progesterone support is lost, and that is in the menstrual phase. And in regards to specific anatomy, you can see this diagram showing the uterus regions. You have the cavity of the body, you have the cavity of the cervix, you have the vagina there, you have the external orifice and the internal orifice, right? And here again we have various anatomy representations in this cartoon. But let's talk about pathology, because that's what we're here for. Ashman Syndrome. You know about Ashman Syndrome. I know for sure you've heard of it. Ashman Syndrome is secondary amenorrhea caused by the loss of the basal layer of the endometrium and scarring. Ashman Syndrome can be a complication of overaggressive dilation and curettage. And it doesn't necessarily need to be over-aggression. I mean, it's a part of the procedure, a dilation and curettage. Go in there and dilate and curettage, basically scraping the lining, right? And if scarring happens, then it's a well-known side effect. Here we can see on hysteroscopy, Ashman Syndrome. Note all the fibrous tissue. And here we can have Ashman Syndrome being visualized utilizing this, as you can see to the right. Note the adhesions within the uterus. And here we have imaging of an amniotic sheet on ultrasound. And here we have more imaging utilizing an ultrasound of Ashman Syndrome. Note the cervix, the uterus, and the fundus locations. Now, if you can see that, you should definitely consider going into radiology. We're going to move on because we're talking about pathology. Now, anovulatory cycle. An anovulatory cycle is a lack of ovulation. An anovulatory cycle results in a proliferative phase that is driven by estrogen without a following secretory phase that's driven by progesterone. Uterine bleeding results from the breakdown and shedding of proliferative glands. Anovulatory cycle is a frequent reason for abnormal uterine bleeding, which you must be aware of, right? So I know a lot of you haven't done your rotations on OB-GYN yet. That's a third year sort of thing in general. But keep in mind, have an ovulatory cycle on your differential, particularly around menarche and menopause. And here is a representation of various phases of severity involved in menstrual cycle disturbances, such as amenorrhea, luteal phase defects, anovulation, oligomenorrhea, and amenorrhea. So these are various things that you should have on your differential for the most part. Speaking of, let's talk about acute endometritis. Acute endometritis is typically secondary to bacterial infection of the endometrium. After baby delivery or miscarriage, there may be retained fetal products. Retained fetal products serve as an infectionitis, right? By that, the bacteria or foreign organisms can adhere to that and just start growing and multiplying and releasing toxins and whatnot, causing issues. Symptoms of acute endometritis include fever, abnormal uterine bleeding, right? Add that to the differential, and pelvic pain. Here we have a very high magnification micrograph showing endometriitis. Note also the abundant plasma cells that are actually diagnostic for the chronic form. Okay. And in acute endometriitis, specifically, you can see various inflammatory cells. And here we can see various histologic sections showcasing infiltration involving the endometrium tissue. And this is actually chronic endometriitis because they are abundant plasma cells. And here we have chronic endometritis, and we know that because we can see abundant plasma cells in this very high magnification micrograph involving endometrial glands. And here we have various histologic representations of chronic endometriitis. Now note here in A, B, C, and D, in A we don't even really see too many plasma cells. B is a specific stain for syndecan 1 that shows numerous plasma cells staining there. C is an H&E slide showing the prominent spindle cell component of chronic endometriitis. And D, you can see the plasma cells being identified in the spindle cell component. Interesting. Now let's talk about another pathology that you should be aware of. Endometrial polyps. An endometrial polyp is a hyperplastic protrusion of the endometrium. Like to the right here, you can see what the endometrium polyps would look like inside of the uterine cavity. Endometrium polyps typically present as unusual uterine bleeding. And endometrial polyps may develop from adverse side effects of medications, such as tamoxifen, you should know that, right? Which has mild proestrogenic effects on the endometrium, but anti-estrogenic effects on the breast. And here we can see various pictures of endometrial polyps, right? You see the pedunculated appearance in the various pictures. And here we can see the histology from an endometrial polyp, Note the myometrium, the endometrial stroma, and the endometrial polyp stroma, right? In the myometrium, we have the smooth muscle cells versus the endometrial stroma, which is more cellular, versus the endometrial polyp stroma, which is more collagenous. And here, utilizing sonography, we can see this circular pedunculated lesion, which is an endometrial polyp. And here we can see more histology showcasing an endometrial polyp. Now let's talk a bit about endometriosis. As indicated in this cartoon here, you can see that endometriosis can involve various structures and organs. Endometriosis occurs outside of the uterine cavity endometrial lining. Endometriosis mostly occurs due to retrograde menstruation with implantation at an ectopic site. Symptoms of endometriosis include pelvic discomfort and dysmenorrhea. Complications of endometriosis include infertility, pain while urinating, pain while defecating, and potential scarring, which increases the risk for ectopic tubal pregnancy. To the right here, for example, we can see endometriosis in the wall of a fallopian tube. Endometriosis cycles the same way as normal endometrium. The ovary is the most frequently affected region by endometriosis, and this typically causes the development of a buzzword, chocolate cyst, right? You hear chocolate cyst, think endometriosis. Other sites of endometriosis involvement include the fallopian tube mucosa, bladder wall, intestine serosa, the pouch of Douglas, and uterine ligaments. Traditionally, endometriosis implants look like yellow-brown gunpowder nodules, grossly, as you can see here in this picture of endometriosis of the abdominal wall. Speaking of which, adenomyosis is the medical term for endometriosis involvement of the uterine myometrium. At the site of endometriosis, particularly in the ovary, there is an elevated chance of developing endometrial adenocarcinoma. Here we can see an endometriosis, particularly in this micrograph of the wall of the endometrioma. All these features of endometriosis are present, such as the endometrial glands, endometrial stroma, and even that golden brown there, that hemosiderin-laden macrophage effect. And here, amongst the numerous glands and the stroma, we notice that the endometriosis is occurring, right? And here, we have another picture showcasing grossly what endometriosis looks like, as well as on ultrasonography. This endometrioma is distinguished from other types of ovarian cysts by somewhat grainy and not completely anechoic content. And here, in the pouch of Douglas, on the right sacrouterine ligament, we can see the endometriotic lesions. And here, we have a surgery undergoing for a patient that was experiencing an ovarian cyst and endometriosis. And here we have a laparoscopic image of endometriotic lesions at the peritoneum of the pelvic wall. Can you see that there? And various stains that are standing for endometriosis, right? Note the glands and the AMH expression in the epithelium. Unlikely that you'll be asked that, so let's move on. To endometrial hyperplasia, you will have to know about this. Endometrial gland hyperplasia is excessive growth of the endometrium. To the right here, we can see endometrial hyperplasia. The histopathology of complex hyperplasia with atypia, note the closely packed endometrial glands with sparse intervening stroma and stratification of the lining epithelium. Endometrial hyperplasia occurs due to increased amounts of estrogen, right? Estrogen's high, endometrial glands are gonna go crazy and start becoming more abundant. Endometrial hyperplasia. Increased estrogen may be present from obesity, PCOS, right? Polycystic ovarian syndrome, and even estrogen replacement therapy. Endometrial hyperplasia typically manifests as uterine hemorrhage after menopause. Histologically, endometrial hyperplasia with cellular atypia is the most significant predictor of development of carcinoma. Atypical simple hyperplasia frequently develops into cancer in 30% of cases. Complex hyperplasia without atypia, on the other hand, seldom develops into carcinoma in about 5% of cases. And here we can see histopathology of complex hyperplasia without atypia. Note the cystically dilated endometrial glands that are lined by the single layer of columnar epithelium. And here we have a micrograph of simple endometrial hyperplasia without nuclear atypia. Note the normal gland to stromal ratio, right, about 1:3, and the proliferating pseudostratified glandular epithelium. And here we have various micrographs showcasing endometrial hyperplasia of various grades. And here we have atypical glandular hyperplasia of the endometrium. And this, my friends, is endometrial carcinoma. We have endometrial carcinoma. And this is the malignant proliferation of endometrial glands. So to the right here in the picture, we have a cross-section of the uterus, right? Patient went surgery, had their uterus removed. It showed up in the lab, was bisected. You're looking at it. You see the internal uterine cavity. And you see all those protuberant growths and that amorphous nodular white lining. That is the carcinoma. Endometrial carcinoma is a female vaginal tract invasive cancer which is most prevalent. Endometrial carcinoma presents as bleeding after menopause, but it can present in other fashions as well. Endometrial carcinoma occurs through two different pathways, typically sporadic or hyperplastic. Carcinoma may develop from endometrial hyperplasia. And risk factors for endometrial carcinoma are linked to estrogen exposure, such as early menarche, right? Or late menopause. Obesity as well, and nulliparity, right? And infertility with anovulatory cycles. All those are risk factors for endometrial carcinoma because they have increased exposure to estrogen. Endometrial carcinoma typically presents around 60 years old. The histology of endometrial carcinoma is usually full of abnormal endometrioid cells. In 25% of cases, the sporadic pathway, right, cancer develops in an atrophic endometrium without any obvious antecedent lesions. P53 mutation is frequent and the tumor behaves aggressively. And here we have a grade 1 adenocarcinoma that was diagnosed by endometrial biopsy that later led on to a hysterectomy, of which you're seeing here now a longitudinal sagittal section through the full length of the uterus. You should be able to see a couple cysts and the mass lesion on the left upper side of the screen. And here again, another picture of the endometrial carcinoma. This time you can probably see it in the upper right area. And more endometrial adenocarcinoma specifically. You see those protuberant bulbous growths and that thick growth with those papillary fronds? Yes, that's endometrial adenocarcinoma. And here we have histology of an endometrial adenocarcinoma at very high magnification. And here we have the gross pathology of an endometrial adenocarcinoma. And this graph, this circular chart showcasing the relative incidences of endometrial carcinomas, most notably endometrioid making up a large majority. But don't forget about the others: papillary serous, clear cell mucinous, and squamous cell. And here we have a vaginal ultrasound with an endometrial fluid accumulation in a postmenopausal uterus, which is a suspicious finding for endometrial cancer. And this is a polypoidal endometrial carcinoma in a very well preserved specimen. And here we have histology from an endometrioid carcinoma with the wild type pattern of P53 expression with a variable proportion of tumor cell nuclei staining with variable intensity with P53. And here we have various histologic panels showcasing various tumors, specifically of the endometrial sort, as well as hyperplasia, right? You can read through this if you want. It's not as high yield as some of the other things that we already talked about. Now, something that is high yield, leiomyomas. You will definitely be asked about this. Leiomyomas are also called fibroids. As you can see to the right, they are somewhat protuberant and bulbous, very bland looking. Leiomyomas are the most typical female tumor, tend to be benign neoplastic growths of smooth muscle that arise from the myometrium. Leiomyomas are associated with estrogen exposure. Leiomyomas are prevalent in premenopausal females. Leiomyomas are prevalent in premenopausal females. And leiomyomas may enlarge during pregnancy and shrink after menopause. On a gross examination, leiomyomas typically have a white, whorled, round mass appearance that could actually encroach on the pelvic tissue and deform the uterus. Leiomyomas are typically asymptomatic, though. When symptoms from leiomyomas exist, they typically include abnormal uterine bleeding, abdominal distension, bloating, and infertility. Speaking of which, let's talk about Leiomyosarcomas. Now, I know that sounds like leiomyoma, but this is very different, right? Leiomyosarcomas are malignant. Leiomyosarcomas are tumors of myometrial smooth muscle that have become malignant. In the panel to the right here, we can see the histopathology of a leiomyosarcoma, showing variable atypia with the cytoplasmic vacuoles and frequent mitotic figures. Of note, leiomyosarcomas can arise de novo, and they tend not to develop from leiomyomas. Leiomyosarcomas normally occur in postmenopausal females, and leiomyosarcomas typically show a single lesion with areas of necrosis and bleeding is frequently visible on a gross exam. Histologic features of leiomyosarcomas include necrosis, multiple mitoses, and cellular atypia. And with that, I'd like to congratulate you on completing yet another presentation. Keep up the good work. I'm so proud of you. You're doing a great job. Very diligent, and I can respect that. You're making everybody proud. Till next time, I'll see you later.